We recently completed a phase 3 trial of Orca-T, comparing that to standard myeloablative conditioning allotransplant. And the enrollment has been completed. And as we wait for the early readout of that data, which should come up sometime next year, at ASH this year, I presented our longest term follow-up to date of our phase 1b trial using Orca-T in the myeloablative setting with single agent GVH prophylaxis of tacrolimus. So the background of Orca-T is that this is a high precision immune therapy composed of stem and immune cells derived from an allogeneic donor that leverages a highly purified and polyclonal T regulatory cell population that is capable of controlling alloreactive immune responses. In comparison, the standard allograft of hematopoietic cell transplantation typically administers all of the cell types at once in a single infusion. In comparison, the Orca-T strategy selects and separates into 3 distinct components. Number 1, hematopoietic stem cells that are infused on day 0. Number 2, purified T regulatory cells that are also given on day 0 but in separate infusion. And number 3, conventional T cells at a reduced dose that are infused on day +2. Now this separation allows for the regulatory T cells to migrate to the solid organs first, so that by the time the conventional T cells arrive, an immune barrier is in place that mitigates graft versus host disease and also optimizes the graft versus leukemia effect by means of Tregs allowing conventional T cell activation without extensive proliferation. So the phase 1b trial presented at ASH this year was our longest follow-up to date of Orca-T. It included 154 patients with AML, ALL, or MDS. And all of these patients received myeloablative conditioning with a KPS of 70 or greater and a comorbidity index of 4 or less. And out of the 154 patients, 3 developed primary graft failure. The rate of severe acute graft versus host disease was only 5%, and moderate to severe chronic graft versus host disease was only 13%. And this led to a favorable non-relapse mortality of 9%. Again, the median follow-up was 30 months, and that led to a 3-year overall survival of 76% of patients with Orca-T. So very favorable follow-up there. The current study also put an interesting perspective on our longest follow-up to date, in that we did an observational analysis of selected patients from the original phase 1b Orca-T trial to a PTCy cohort that was obtained from a published CIBMTR registry study. So from both original studies, we selected a patient sample who would have been eligible for the phase 3 Orca-T trial and then compared them. And we used a log rank test to see if there was any difference in overall survival amongst the treatment groups. And what we found was that overall survival was significantly better with Orca-T in comparison to a similar cohort of patients who received PTCy, corresponding to a p-value of 0.002. So it's interesting to put this in the perspective of 2 emerging strategies in myeloablative conditioning setting, which can lower the non-relapse mortality to around 10% and lower. One utilizes an interesting immune therapy that's novel, plus tacrolimus, single agent GVH prophylaxis, and then the other strategy uses triple agent GVH prophylaxis, including a chemotherapy.